Hello everyone, my name is Jonathan Wendell. I'm the Medical Director for Anne Arundel County Fire Department. Within the state of Maryland, we are never far from bodies of water. Treatment of patients involved in boating, swimming, or other water-related emergencies is a key feature of the Environmental Emergencies section of the Maryland Medical Protocols for EMS. Recent research, including a 2024 study by the Centers for Disease Control, has documented a notable increase in both fatal and non-fatal submersion injuries globally over the last 5 years. These trends are also apparent in Maryland, prompting a re-examination of the current science on submersion injury management and the recommendations for treatment within our protocols. Upon review, it became evident that our current near-drowning protocol does not align with the latest research. To improve outcomes, it is crucial that our protocols reflect the most up-to-date evidence. The changes you will find in the 2025 protocols include updated terminology, streamlined care for the basic life support BLS to advanced life support ALS levels, and alignment with current best practices in resuscitation science intended to enhance the effectiveness of the drowning treatment protocols. In this module, we will review the new submersion injury and submersion injury with cardiac arrest protocols. We will finish with the discussion of cold emergencies and the modifications to the treatment of hypothermic cardiac arrest patients. The first thing you will notice is that the terms near drowning and drowning have been replaced by submersion injury and submersion injury with cardiac arrest. Submersion injury is defined as respiratory impairment caused by immersion or submersion in liquid. It is important to note that previously used modifiers such as near, wet, dry, active, saltwater, freshwater, delayed, or secondary drowning are no longer considered valid or clinically meaningful. Their use has been discouraged as these terms lack precision and do not contribute to the clearer understanding of patient care. Not only has the near-drowning protocol been renamed, it has also been divided into two separate protocols: submersion injury and submersion injury with cardiac arrest. Let's look at the submersion injury protocol first. This protocol applies to both adult and pediatric patients. Indications are immersion or submersion of a patient without cardiac arrest. Patients may present with altered level of consciousness, dyspnea, cyanosis, vomiting, seizures, wheezing, or decreased air entry presumed to be due to bronchospasms. Indications are further classified by severity: mild, moderate, and severe. For mild, patients may have mild dyspnea. Patients are usually alert with no loss of consciousness. They may have involuntary or distressed coughing, but the pulse ox is generally greater than 94% without supplemental oxygen, and they have adequate perfusion. For moderate patients, they may have moderate dyspnea. The pulse ox may be less than 94% on supplemental oxygen. They are usually unable to speak in full sentences due to their breathing difficulty. They may have previous loss of consciousness, and their exam may show rales, pulmonary edema. They are usually normotensive and altered mental status. For patients with severe, they're usually unresponsive, hypotensive. Their exam shows severe rales or pulmonary edema, leading to even respiratory failure. They may have foaming in the upper airways, and their pulse ox is generally less than 90% with supplemental oxygen. As we scroll down to the treatment portions of the protocol, note that since these cases are primarily respiratory emergencies, treatment should prioritize the rapid reversal of hypoxia. You also notice that consideration is now given to water temperature and submersion time. BLS treatment should include immediate removal of the patient from water. Treat and prevent hypothermia. Refer to the cold emergencies protocol. Assess for the severity of the patient's dyspnea. For patients with a pulse oximetry less than 94%, administer oxygen per the general patient care protocol. Ascertain the water temperature and submersion time. If the patient is unresponsive, give 5 rescue breaths and refer to the GPC Section D. Breathing for age-appropriate ventilation rates. Consider spinal motion restriction per the trauma spinal motion restriction protocols. ALS care for all patients should include monitor cardiac rhythm and capnography and treat according to the appropriate algorithm. Perform a 12-lead EKG. Further ALS care is determined by the severity of symptoms. Mild, administer oxygen as needed based on the general patient care protocol. Treat the bronchospasm following the asthma/COPD protocol. For moderate, provide appropriate high-flow oxygen. Assist ventilations with bag valve mask ventilation as needed. Consider CPAP for patients 13 years of age or older and/or intubation. Be aware that PEEP may need to be increased. Be prepared for these patients to rapidly deteriorate to severe criteria. Treat bronchospasm per the asthma/COPD protocol. Establish an IV or IO access. For patients with severe symptoms, if the patient is unconscious, provide 5 rescue breaths. For conscious patients, 13 years of age or older, apply CPAP with a PEEP of 5 to 10 centimeters of water or BiPAP for those jurisdictions participating in the BiPAP optional supplemental protocol. Treat bronchospasm following the asthma/COPD protocol. Consider an advanced airway. If conditions allow, intubation is preferred. If you are unable to intubate, an extraglottic airway is acceptable. If blood pressure is less than 90, administer a fluid bolus of 250 cc's of lactated ringers. If needed, one additional 250 cc bolus may be administered. If the patient remains hypotensive despite IV fluid, administer an epinephrine infusion titrated to a systolic blood pressure of 90 or a MAP of 65. Moderate and severe submersions are considered traumatic injuries to the lungs. These patients should be transported to an eCPR-capable center or a trauma center if the patient condition allows. Under medical consultation, we see that the pediatric patients whose parent or guardian is refusing medical care or transport, a medical consultation with a pediatric base station shall be obtained prior to completing the patient-initiated refusal. Clinical pearls include: abdominal thrusts are contraindicated unless the patient has a foreign body airway obstruction. Clinicians should enter the water only if trained and, as a last resort, reach, throw, go with assistance. Even if the patient appears to be uninjured or completely recovered, all submersion victims who are not in cardiac arrest should be transported to the closest appropriate facility, at minimum, due to the risk of delayed pulmonary edema. You were dispatched for a boater in distress after his kayak overturned. Bystanders tell you they saw him disappear under the surface repeatedly before the local fire department rescue boat crew pulled him from the water. Your patient is a 14-year-old boy who is alert and oriented. He denies any loss of consciousness. He has mild dyspnea with frequent involuntary coughing. His pulse ox reading is 96% on room air. How would you categorize this patient's submersion injury? A, mild, B, moderate, or C, severe? A, mild, is the correct answer. The boy's parents are on the scene and tell you they do not want the patient to receive care or transport to the emergency department. You need to obtain a medical consultation with a pediatric base station prior to completing the patient-initiated refusal. A, true, or B, false? The answer is A, true. While you are assessing the patient and preparing to transport him to the local hospital, his symptoms worsen. He is now in moderate respiratory distress with pulmonary edema. His room air pulse ox readings drop to 89%. Despite supplemental oxygen via non-rebreather mask, his SpO2 is still low at 90%. He is conscious and alert. You should consider CPAP for this patient. A, true, B, false? The answer is A. The patient is over 13 years of age with moderate dyspnea and pulmonary edema. CPAP would be the appropriate treatment. Now let's turn to the submersion injury with cardiac arrest protocol. Indications are cardiac arrest from submersion injury in patients 18 years and older. For patients less than 18 years old, refer to the pediatric cardiac arrest protocol. There must be no signs of trauma. If trauma is present, refer to the trauma arrest protocol. BLS treatment includes remove the patient from water, follow the cardiac arrest protocol until ALS arrives. Early focus should be on effective bag valve mask ventilation. Perform high-quality, uninterrupted chest compressions, which may be done either manually or via mechanical CPR. Apply an AED as soon as possible and follow the prompts. ALS treatment is based on water temperature and estimated submersion time. Submersion time is the most important factor in determining survival, with water temperature playing an important secondary role. Full resuscitation should begin or continue while water temperature and estimated duration of submersion are determined. Let's look at warm water submersion first. Remember, warm water is defined as greater than 43 degrees. In cases of warm water submersion, with a submersion time of 30 minutes or less, perform a full resuscitation. Prioritize early intubation and consider increasing PEEP. An NG or OG tube should be placed early. Resuscitation may be terminated if the patient has received 15 2-minute cycles of high-performance CPR and is in asystole or is in VF, pulseless VT, or PEA with an end-tidal CO2 less than 15. For warm water submersion with estimated submersion time of greater than 30 minutes, place the patient on a cardiac monitor. Pronouncement of death can be made if the patient is in asystole. For rhythms other than asystole, initiate full resuscitation. Resuscitation may be terminated if the patient has received 15 2-minute cycles of high-performance CPR and is in asystole or is in VF, pulseless VT, or PEA with end-tidal less than 15. Now let's turn our attention to cold water submersion. When the water is cold and estimated submersion time is 90 minutes or less, initiate a resuscitation and transport to an eCPR-capable center. Consider helicopter transport if drive time is greater than or equal to 45 minutes from the closest appropriate facility. Obtain early medical consultation for hypothermic cardiac arrest patients, as drug and defibrillation intervals may change depending on the degree of hypothermia. If the water is cold and submersion time is greater than 90 minutes, place the patient on a cardiac monitor. Pronouncement of death can be made if the patient is in asystole. For rhythms other than asystole, initiate resuscitation and transport to an eCPR-capable center. Consider helicopter transport if drive time is greater than or equal to 45 minutes from the closest appropriate facility. Obtain early medical consultation for hypothermic cardiac arrest patients, as drug and defibrillation intervals may change depending upon the degree of hypothermia. If ROSC is obtained, refer to the ROSC protocol and transport. The preferred destination for submersion patients is an eCPR-capable center. Consider helicopter transport if drive time is greater than or equal to 45 minutes from the closest appropriate facility. If submersion time is unknown, refer to the adult termination of resuscitation medical arrest protocol. If the patient does not meet medical TOR criteria, continue resuscitation and transport. Note that the TOR criteria no longer include submersion as an exclusion. In the clinical pearls, you will find criteria for determining warm versus cold water submersions. Warm water submersions. Water temperature above 43 degrees Fahrenheit or 6 degrees Celsius. Generally, this will occur in late March to November for most bodies of water in Maryland. Cold water submersion is water temperature below 43 degrees Fahrenheit or 6 degrees Celsius. December to March for most bodies of water in Maryland. Your BLS ambulance crew is the first EMS unit on scene at a marina where a 35-year-old woman was just pulled from the water, unconscious after falling from her boat into icy cold water. Bystanders tell you they saw her slip and fall. The patient became submerged almost immediately, and it took them more than 90 minutes to locate her in the water and pull her onto the dock. You assess the patient and quickly determine that she is unresponsive, apneic, and pulseless. Your action should include A. Pronouncement of death, B. Begin high-performance CPR, C. Apply your AED and follow prompts, D. Both B and C. The correct answer is D. You should follow the cardiac arrest protocol until the arrival of ALS. This includes high-performance CPR and the use of an AED. It is mid-December, and you are the first arriving unit on scene at a marina where a 35-year-old woman was just pulled from the water. She is unconscious after falling from her boat into the icy cold water. Bystanders tell you they saw her slip and fall. The patient became submerged almost immediately, and it took them more than 90 minutes to locate her in the water and pull her onto the dock. You assess the patient and quickly determine that she is unresponsive, apneic, and pulseless. You place the patient on a cardiac monitor and determine her rhythm is PEA. Your action should include A. Immediate pronouncement of death, B. Initiate resuscitation with high-performance CPR, C. Transport to an eCPR-capable center, D. Both B and C. The correct answer is D. The patient is submerged in cold water for more than 90 minutes, and her rhythm is not asystole, so you should initiate resuscitation and transport to an eCPR-capable center. We now turn to cold-related emergencies. Transport considerations for patients with severe hypothermia or in cardiac arrest secondary to hypothermia are similar to the considerations we have already discussed for cold water submersion injuries. Here we are directed to transport patients with severe hypothermia, including low blood pressure and heart rate, and patients in cardiac arrest to an eCPR-capable center, unless there is an injury incompatible with life. If the patient can't be delivered to an eCPR-capable center within 30 minutes, go to the closest facility. For patients less than 18 years old, transport should be to a pediatric eCPR-capable center if transport time is within 30 minutes. Otherwise, go to the nearest facility. Remember that hypothermic patients in cardiac arrest may survive after a prolonged downtime. Hypothermia remains a contraindication to the termination of resuscitation protocol. Hypothermic patients who are bradycardic and/or hypotensive may benefit significantly from transport to an eCPR-capable center to allow for extracorporeal warming. You are treating a 10-year-old girl suffering from severe hypothermia. She is unresponsive. Her skin is cold and her muscles are stiff. There is no evidence of trauma. Her respirations are slow and shallow with a rate about 6. Her pulse is 40 beats per minute, and you are unable to obtain a blood pressure. High-performance CPR is in progress. Which destination is most appropriate? A. Freestanding ED 5 minutes away. B. Local hospital 10 minutes away. C. eCPR-capable center 20 minutes away. Or D. Pediatric eCPR-capable center 25 minutes away. The correct answer is D. The pediatric eCPR-capable center 25 minutes away.